The pathophysiology of DKA can get a bit complex, so it's helpful to remember what normal processes look like. The body can use glucose and ketones for energy. However, the body prefers glucose. The brain actually prefers glucose as a source of energy. Now let's look at a really simplified version here. You've got the cell, and you have an insulin receptor. Of course, you have insulin, and then extracellularly, you have glucose. Now, we can think of insulin as the gatekeeper for the cell. Glucose needs insulin in order to get into the cell, specifically to the mitochondria, where the Krebs cycle, which we all remember, produces ATP, which the body can then use. Now, in DKA, there is a decrease in insulin or absolute insulin deficiency. So let's look at the cell. Still have your insulin receptor. You still have glucose that's extracellular with the intentions of wanting to get intracellularly to create energy. However, as we said, there is no insulin. The glucose cannot get into the cell, and you have an increase of your glucose extracellularly, which leads to cell starvation. So your increased glucose leads to a state of hyperglycemia. We will go over all 5 of these, which are the 5 components of the pathophysiology of DKA. So your cell is starving and your body needs an alternate source of energy, which is not the preferred method, and it gets a little messy. The body starts going into what's called starvation metabolism. Muscles are broken down, fats are broken down. Specifically, let's look at the adipocyte, which is the fat cell. It goes into a process called lipolysis, and the end result is a free fatty acid. Now, this free fatty acid travels to the liver, and a bunch of other complex processes happen. The end result, however, is ketones. Now, it's important to remember that ketones are acids, and the body is starving, so it has a dramatic response. Excessive amounts of ketones are created. Some of them do get utilized, but there's an excessive amount of ketones in the blood, in the body, circulating around, which creates and leads to the second component of the pathophysiology, which is the metabolic acidosis or ketoacidosis. It's the same thing. So let's kind of do a recap here. We have no insulin in the body. That should be a downward arrow. So no insulin, go back to the free fatty acid, to the liver, which produces your ketones. And with ketones in excessive amounts, this leads to a state of acidosis. And then one of the big ways that we measure that acidosis is an anion gap. Usually it's greater than 12. Now, with your decreased insulin, you've gotten an increase in glucose. One of the things that's important to remember with your anion gap and your acidosis is that the potassium, which is intracellularly at this point, moves extracellularly and increases extracellularly, which is important when it comes to treatment, which we'll talk about later. So here in the kidneys, I'll just kind of blow up the kidneys here and look at what's called reabsorption threshold. the kidneys and the body reach a level where there's too much glucose circulating, and the body does try and compensate in different ways to get rid of the imbalances that are occurring. So with the reabsorption threshold, your glucose is usually greater than 225. Some sources say greater than 300. But the result here is that the kidneys start to dump out the glucose, which with glucose goes water. Lots of water, which creates a state of osmotic diuresis, which is our third component of DKA. So we have to discuss here, with water goes sodium. These patients will be hyponatremic. And with sodium, as your potassium has moved extracellularly, potassium and sodium will be deficient, and you will see electrolyte shifts and volume depletion. Volume depletion is really important. These patients come in profoundly dehydrated. Let's start talking about some of the clinical manifestations that we see. One we just talked about, which is dehydration. Also, as we talked about, with the large amounts of water leaving the kidney, you will see these patients complain of peeing a lot. With peeing a lot, this contributes to your dehydration that you see. Now let's talk about when the adipocyte creates the free fatty acid, there's a byproduct here. And this is really important in contributing to our next clinical manifestation. You've got inflammatory cytokines that come out of this process, and they irritate the stomach lining, and they lead to abdominal pain, nausea, and vomiting, which contributes to your overall volume depletion and dehydration. Next, as we said before, the body's trying to compensate. So when there's excessive amounts of ketones, the body is going to try and get rid of these. One way that it does that is by increasing the respiratory rate, the Kussmaul breathing. Trying to breathe off the acid. Secondly, there's a byproduct of ketones called acetone. This is what contributes to the sweet breath that often DKA patients present with. Lastly, tachycardia is a compensatory mechanism with the volume depletion. Next, let's talk about lab values. So, with that profound amount of ketones, creates a profound acidosis, which lowers your pH to lower than 7.3. Now, glucose greater than 200, we already discussed that. Ketones in your blood and urine, you're going to see as the body tries to again compensate, trying to get rid of the ketones in the urine and the ketones in the blood will be there. Lastly, we already talked about glucose in the urine. And then let's talk about the fact that your ANA and GAP is going to be greater than 12, which leads to the treatment of this.